Hi, I am Francisco Ponce, and I'm a neurosurgeon at the Barrow Neurological Institute. I'm going to be discussing MR-guided focused ultrasound and what to expect with treatment and what the treatment consists of. So part of this is to provide you with what you need so that you can make informed consent. So part of a procedure is the patient signing an informed consent permitting the surgeon to perform a procedure. And in order to be capable of providing informed consent, a patient has to understand the risks, the benefits, the alternatives, and the indications for the procedure that's about to be performed. So first thing that I find important is in this procedure is understanding what a thalamotomy is. So with MR-guided focused ultrasound and treating essential tremor, we're performing a thalamotomy, and it's essential that you understand this. So what is a thalamotomy? So this is a term that you should be familiar with if you're going to undergo this procedure. So this is kind of a crash course in medicine. A thalamotomy refers to an ablation of the thalamus. So the thalamus is a part of the brain, and thalamotomies have been performed for well over 50 years, since the 1950s. And at one point, they were performed using an open procedure where somebody would, a surgeon would open up the head and go in and cut off the blood supply, basically cut off an artery, intentionally perform a stroke. And what this image to the right shows is an MRI of the brain. And what you see, the white ring, is a thalamotomy. That's a stroke that was intentionally created in order to treat tremor. So in the 1950s, they learned that a stroke in this area could actually be therapeutic, could help by just stopping a tremor. And it turns out that at that time, the procedure was not so specific that sometimes this would cause complications and sometimes it would provide benefit without complications. So the results were variable. So a thalamotomy has been around, and it's basically a word to describe intentionally creating a lesion, an ablation of the brain. So it's been used for over 50 years to treat tremors. And the manner by which a thalamotomy is performed has evolved over time. So it went from being an open procedure to drilling a small hole through the skull and inserting a probe, and actually using the probe to heat up the tissue to the point that the brain cells would die. So still creating a stroke, and that probe would be inserted through the brain. Later on, using the same radiation treatment that can be used for tumors, they used focused radiation to create an ablation as well, and now focused ultrasound. So focused radiation uses focused radiation rays to create an ablation, but it turns out with radiation, the ablation does not happen immediately. It happens over time. So there's a delay before the therapeutic effect of that procedure occurs. And once that radiation is administered, there's nothing we can really do to adjust what happens with the process of cell death that is induced at that time of therapy, but it doesn't occur for months. And the benefit of focused ultrasound is that using an MRI, we can actually track the temperature of that tissue. So we're heating the tissue at the time of therapy, creating the ablation so that people leave the therapy with their tremor controlled. Unlike focused radiation. With the probe, with the thalamotomy that's performed using drilling a hole in the skull, that procedure, similar to focused ultrasound, patients would leave with the tremor controlled. However, it obviously is an invasive procedure. We place a probe through the brain, and patients would have to be awake for this procedure to verify that the place where the ablation would be performed was the correct spot. So they would check, double check, triple check, looking for side effects, clinical benefits before creating the lesion. And likewise with focused radiation and focused ultrasound, patients are awake. It's also important to be aware that the treatment occurs on the day of the procedure, and there's no real adjusting that we can do after that. So it's irreversible and it's not adjustable. So when somebody has an accidental stroke, for example, of the brain, a stroke is not a reversible event, and we're basically creating a stroke when we do a thalamotomy. And so what you see is what you get, and I'll talk about this a little bit later, but when that's the situation, it's better to undertreat than to overtreat in order to prevent complications. Also, thalamotomies historically were only produced on one side of the brain. So there are side effects that are observed when we do these lesions, these ablations on both sides that we don't see when we do unilateral ablations. Now, recently, focused ultrasound was approved for bilateral treatment, meaning we can treat both sides of the brain, meaning that if you have both hands shaking, you can actually treat both hands doing focused ultrasound. However, there has to be an interval between the two treatments of 9 months. That's what the new approval stipulates, that there has to be a 9-month window between treating the first side and the second side. And one thing that I try to emphasize, and that's been kind of the tone that the neurosurgeons nationally have emphasized as well, is a reluctance to call this minimally invasive or non-invasive. Especially when considering the alternative deep brain stimulation. A large appeal of this therapy, focused ultrasound, is that we don't have to use a scalpel. We're not implanting hardware. However, we are creating an ablation. We are doing a procedure that creates a stroke that damages brain cells. And as such, there's a reluctance to market this as minimally invasive or non-invasive, at least from the perspective of the neurosurgeon. In terms of alternatives, medical management, it's a part of the indications for this as well, that you've trialed medical therapies for this and that they've not worked. But you can consider various medicines. The only one that's approved by the FDA for the treatment of essential tremor is propranolol, but many people have tried or are on primidone. So medical management is always an alternative. You don't have to proceed with an ablation. Also, deep brain stimulation has been the standard surgical treatment for decades now. And the appeal of deep brain stimulation is, in addition to being able to treat both sides at the same time, that it's non-destructive, it's reversible, and it's adjustable. And that's what the pacemaker is. The pacemaker is the source of the programming that you can make the adjustments with. So insofar as understanding this paradigm, I think it's useful to compare it to pacemakers. So a cardiac pacemaker, right? How do you treat an abnormal heart rhythm? You can treat abnormal heart rhythms with medicine that a cardiologist will prescribe. You can actually do an ablation. So a cardiologist can go in and find a node within the heart to create an ablation to interrupt that abnormal heart rhythm. And you can get a heart pacemaker. So heart medicines, heart ablations, heart pacemakers. Similarly with essential tremor and with these brain conditions, you can do ablations, medicine, or a pacemaker. So deep brain stimulation functions like a pacemaker for the brain. And likewise, you can opt to undergo a thalamotomy by an alternative mechanism like radiation or inserting a probe into the brain invasively. That's very uncommon. However, some people are not candidates for focused ultrasound due to their skull density. But that being said, thalamotomies by other alternative means are becoming less and less frequent. So again, part of informed consent is understanding the indications and the benefits, anticipated benefits. Obviously, benefits speak for themselves. You want your tremor to stop, right? So essential tremor, MR-guided focused ultrasound is approved for the treatment of essential tremor that cannot be controlled by medication. So that's a criteria. Approval is for treatment of one side of the brain at a time. So the at a time is new, meaning that it has been approved for second side, but that has to be 9 months later. And patients have to be a minimum of 22 years of age. Tremor dominant Parkinson's has also been approved for focused ultrasound. It's approved to treat patients with Parkinson's disease whose main symptom is tremor. The target we use that's been approved at this time does not treat the other movement conditions such as stiffness and slowness, rigidity, bradykinesia. That's under investigation at this time. And at this time, at least in Arizona, tremor predominant Parkinson's disease is not covered under insurance, even though the FDA has approved it. And that's likely to change and perhaps will change while I'm still using this video. So that's subject to change. And patients must be a minimum of 30 years of age. And again, these approved indications are changing as are coverage policies by insurance. So things to think about before you undergo this therapy, and you'll be given a sheet with this information. For essential tremor, don't take your tremor medicine the night before or the morning of treatment. And part of that is just because we want as much of an untreated tremor as possible to chase that tremor at the time of therapy. Also, do not take blood thinners or anti-inflammatory medications such as aspirin, ibuprofen, Plavix, Coumadin, Eliquis, Brilinta, Xarelto, Coumadin, and so on for a minimum of 4 days before the procedure. If you are on blood thinners, it's important that you check with your prescribing doctor to ensure that it's safe for you to stop these medications. So you stop these medications at your own risk, and your cardiologist or your primary care doctor can help inform you of the risks of stopping these therapies, but you can't be on these therapies at the time of treatment because of the risk of brain bleeding. Again, you may continue to take the remainder of your medications without interruption. And about 2 days after a focused ultrasound, you can resume these anti-inflammatory blood thinners. When you come to the hospital, your head will be fully shaved. So this is a picture taken from the internet, not one of my patients. And this gentleman has hair, but the hair will actually be clipped all the way down to the scalp before the frame is placed. Also, as I'm placing this frame, you will be fully awake. You will not be sedated. I will give local anesthetic, like a little injection above the eyebrows, behind the head, 4 spots at the site of the pins to help with the numbing. You will feel pressure, but it's important that you are confident that you'll be able to tolerate having this device placed on your head because you will not be sedated. And you will feel pressure, and any pain I will chase with additional local anesthetic, numbing medication, and you'll be in this frame for a few hours. The procedure takes place in an MR scanner. So this is what it looks like. Again, a picture I've taken off the web. So in terms of patient confidentiality or whatnot. But what you see here is a patient is flat on the MR scanner. You can see their feet are elevated. They actually have a cap that's been placed over their scalp. So you can see a little bit of the stereotactic frame, but also the cap is watertight. So we're flushing cold water over the scalp because during the procedure, the scalp and the bone actually heats up. So this is used to keep the scalp cool, and in so doing also keeping the bone cool. So during the procedure, the patient rolls into the MR scanner and back out a number of times. And I actually test the patient's tremor just like this. So the patient's going to be laying flat with their hand up in the air, drawing spirals as we evaluate for side effects and clinical benefit. During these test doses, we can actually administer test doses to stun the brain before we give the ablative dose. That's kind of like we give like 2 final doses typically. So you won't be sedated. Your skull will heat up during the ablations, and this can take up to 30 to 60 seconds, but typically it's less time than that, about 10 to 15 seconds. And during that time, you may feel like your feet are kind of falling behind your head, like you're falling in space. In addition, insofar as what we're looking for speech side effects, sense of tingling or numbness in the mouth, tongue, or body, any motor weakness, as well as the clinical benefit of the tremor stopping. And again, expect to feel unsteady after the treatment. Bring a walker, a cane, or something. Take precautions not to fall, but just be aware that one of the most common side effects after the procedure is to have a sense of unsteadiness. To summarize, again, all your hair will be removed. We'll use an electric clipper followed by an electric rotary shaver to really get the scalp all the way down, the hair all the way down to the scalp, so that when you feel it, there's no bumps. And that's basically because of the water that's placed to facilitate with the ultrasound energy so that the ultrasound can be administered effectively. Typically on the day of the procedure, I'll give you Tylenol, Decadron, which is a steroid, and Zofran, which is an anti-nausea medication to help control for symptoms that may occur during the procedure. You'll get the local anesthetic to 4 points in the scalp. This is a mixture of lidocaine, marcaine, and epinephrine, which will help numb the 4 sites where the frame will be placed. And again, be aware, you're not going to be sedated. I don't schedule these with an anesthesiologist. There won't be an anesthesiologist available for this treatment. After discharge, this information is going to be provided to you on a sheet of paper that I give you at the time of clinic. Medications, will typically order a Medrol dose pack to your pharmacy so that you can pick it up before the day of procedure, and you'll start taking that as soon as you get home. This is a steroid. It'll help with swelling in the brain and help with the symptoms that may occur because of the swelling. So you can pick this up before the day of treatment and start taking it as instructed on the day of your procedure. So when you'll have 6 pills on the day of the procedure, and you can take the first 2 pills as soon as you get home, 2 right before or after dinner, and then 2 at bedtime. So take the 6 pills for the first day. Take all of those before you go to bed. You're not going to take in the morning, because in the morning you're going to be at the hospital getting this procedure. So take all of them before you go to bed that night. Fall precautions, again, I emphasize this, you will feel unsteady for a period of time after this procedure. So bring a walker, a cane, or a wheelchair to assist with balance. Just anticipate this and make plans for it. Watch your step, take precautions not to fall. Other symptoms may include dizziness, numbness, or tingling, and these effects are usually transient and will improve over time. Wound care, there's going to be 4 points where the pins were placed. So when you go home, you'll probably have a Band-Aid there. And this will be above the eyebrows, behind the ears. Band-Aids and ointment will be applied to those areas, and you may remove these and shower the day after your procedure. Driving after the procedure, you're required to have companion drive you home after the procedure. You cannot drive yourself, and you may not drive for 2 weeks just because of the swelling that's occurring inside of your brain. And for your follow-up appointment, I'll see you about 3 to 4 weeks after the day of treatment. So again, part of informed consent implies that you are aware of the risks and potential complications associated with this. And that's what we acknowledge when you sign the consent. So I do not guarantee that your tremor will be controlled to your satisfaction. So I'll repeat that. I do not guarantee that your tremor will be controlled to your satisfaction. So I don't guarantee the outcome. In addition, most side effects are temporary, but they may be permanent. The most common side effects include nausea, headaches during the procedure, mild to moderate numbing and tingling in the fingertips or lips, unsteadiness in your walking, balance problems, and speech or swallowing problems. And these side effects could start several days or weeks after the treatment, so just be prepared. Longer-term risks and complications with MR-guided focused ultrasound include the tremor could return months or years after the treatment. The tremor may not improve at all, so just be aware of that. So when I see you at 3 to 4 weeks, we can come up with a game plan. But again, remember that if I make a lesion that's too big, I could cause permanent side effects. And because the goal of this is to improve your quality of life, if I create a side effect that impacts your quality of life, then the benefit of not shaking is basically could be undone or worsened by the side effects, including unsteadiness of gait, difficulty speaking, things of that nature. Longer term, meaning 3 months or longer, or permanent side effects may occur in 10 to 15% of patients. And this could include muscle weakness, unsteadiness, sensory loss, meaning numbness or tingling of fingers or other parts of the body. So it's important to be aware when undergoing this, that by virtue of creating a stroke in a very small area of the brain, surrounding that area are other areas, including sensory, motor function, speech, and as that lesion bleeds into those areas, that could cause additional side effects. When considering a procedure, it's always important to be aware of catastrophic outcomes. I don't expect these to occur, but peri-procedural death, debilitating stroke, or other catastrophic outcomes are never expected, but are always a consideration when undergoing an intervention. So when considering this, for example, if you have heart problems, the stress of being in the frame, the stress of going through this procedure could cause a heart attack. It's important that you assess you're aware of your medical conditions. You discuss with your primary care doctor or your specialist that you're going to undergo this. I've had patients with pacemakers undergo this. I've spoken to patients who require oxygen, with an oxygen tank that they go around with. These are all considerations. People who undergo this procedure may often be elderly patients who are not candidates for deep brain stimulation, for example. So they come in with medical conditions. And the scenario I think about is where if somebody were to have a complication, a catastrophic outcome that wouldn't have happened had they not undergone this procedure. It may not be, the process of administering the ultrasound by itself, but it could indirectly influence how the next 6 weeks go, and that complication may be related indirectly, perhaps, but nonetheless related to them having undergone this procedure with me. So just be aware of this as part of the scope of complications, although something catastrophic is not expected, and I would expect to be extremely rare. So thank you for your looking at this. And again, these are usually fun days, happy days where patients get to go home different than how they were when they came in with satisfactory outcome with their tremors. So with that, I look forward to seeing you.